But you have to remember two things. Number one, never use more than your physician prescribes. Very important, because there are side effects, and you don't want to run into those side effects. Secondly, Tylenol is quite expensive, and ibuprofen will do the same job. It's the exact same thing, and it costs about half as much. So don't get carried away with the prescription names when you can use a generic, just for your interest's sake. We'll move ahead to the next stage, and if the slide will move ahead. The next stage is prescription drugs. And these you have to be a little more cautious of, in particular because of side effects with some, and with some others, you may find that you want to use them a little more often than you should.
Hello.
But the first ones are known as NSAIDs, non-steroidal anti-inflammatory drugs, or NSAIDs. But these really decrease the pain, the swelling of the joints. They do not prevent further joint damage, and that is really important. And you only take them as needed because of the side effects. And one of the side effects is shown in the diagram there. They can cause stomach ulcers if you take too many too often. They definitely cause diarrhea and nausea. And these are only the most common side effects. So you have to be very, very cautious with these. And please, please, please listen to what your physician has to say, and make sure you tell your physician exactly what is happening when you take those drugs. Really important.
Interactive.
The next step, of course, are what are known as COX-IBs, or COX-2 selective inhibitors. And these are a form of NSAID, but they directly target the enzyme responsible for the inflammation and pain. And they do reduce the risk of stomach and kidney side effects. However, once again, they have side effects, so it's really important that you listen to your physician. And the side effects primarily are risk of cardiovascular events, such as angina, stroke, and heart attack. So you never take more than you should. You listen carefully, and you only take them upon need. That is just so important, and I just can't stress that enough for you. Well, then there's another type, which we'll say that you had the prescription drugs, the two types. You're concerned that you're going to need them more than you really should. We can get on to something else, which is helpful, especially in between times of using the prescription drugs. And the first one is narcotic analgesics. These are very powerful medications that help control pain. However, because they have to go across the skin membrane and the membranes in the other tissues, only a small percentage gets across. It takes a longer period of time before it gets across, before you start to really feel the subsidization of joint pain and stiffness. However, for some people, they are really important to use, especially if you're starting to feel any addictive effects of or your physician is suggesting any addictive effects of the other types of narcotics. Then another thing that can be done is viscosupplementation. This isn't a lot of fun, but what happens is that you will get an injection right into the knee joint itself. And do you feel this? You feel a little bit, yes, at the time, but does it scare you if you look at it? Yes, it does a little bit, because it's a good-sized needle. But what it is attempting to do is to lubricate your joint. And by lubricating your joint, you cut back on the effects of the the wearing down and fragmentation of the cartilaginous tissue. But you can only have this done periodically, and if you have a good-sized tear in the synovial membrane, it may or may not help. So what do we go to next? On this, and believe me, I can actually speak to this about this because I've been through the whole gamut. And I know what's fun and what's not fun. And the farther we get down the medication, the less fun it really is. The next one is a prescription medication, and that's a corticosteroid. And once again, this is a very large needle, and it's depending the joint, and it's injected into the joint. When I had it injected into my knees or my shoulders through athletic injuries, I just sort of closed my eyes because that was a good-sized needle. It has a frequency pattern pending how much of the corticosteroid is injected. So usually with knee or shoulder, once a year is enough. Anything more, and you have a problem because the corticosteroid starts to essentially eat and damage the cartilaginous tissue. So even though it's helping you protect for a while by lubricating the joint, it is at the same time damaging the cartilage. And for smaller joints, maybe 3 to 4 times a year. But remembering that what is going to happen in the long run. And so it's not one that your physician will recommend on a regular basis. But it does, for example, the effects last approximately 3 months if you don't have a very large tear in the synovial membrane. Well, then there's also a next step, and that's complementary therapy. And you hear a lot about this today. Did you take your glucosamine or chondroitin pill? You can buy them in great volumes at Costco at a pretty low rate. But I should tell you that the evidence, the research, the science behind these use would suggest that the information, the evidence is conflicting. There is no unequivocal proof that these really help at the present time. However, maybe in the future. And now we're getting down to the last step in the spectrum, and that is surgery. And there are 3 types of surgery that you can go through. You can go through arthroscopy, which is essentially a washing out of the loose fragments. You'll see that a lot of times you'll see a football player, he had arthroscopy from a knee injury in a game, and he'll be back in 3 weeks. Well, he probably will because they just washed out the floaters and so forth, and at the same time lubricated the joint a little bit. Then you can go to osteotomy, which is a slightly different, if only part of the joint is damaged or deformed, then you can have a realignment surgery. And this is major surgery. You'll spend a few days in the hospital before they force you to get up and move that joint. And you won't be doing anything serious for 3 to 6 months. However, when the surgery is completed, you're going to feel one heck of a lot better about everything. And the final one, of course, is total replacement, and that's osteoplasty. And believe me, having gone through a double, that is not a lot of fun, but you regain so much use of your knee with time. And as a result, you can do many of the things other than running, of course. You can walk, and you can walk quickly. You can walk on a treadmill, but you just won't be putting a great deal of pounding pressure on the particular joint. In this case, I'm talking about the knee. Okay, now where do we go from here once we've gone through all this process? How and what could we have done to help these particular things as we're going through? Well, there is an approach to take, and you have to realize that, number one, and as a matter of fact, there's an article in this morning's Winnipeg Free Press, which has come across the National, and it is essentially an identification by physicians that they do not take any course in exercise management, and yet they're expected to help prescribe exercise. And they can't do that. So what is happening now is, in particular, many hospitals in large cities across the country, they're forming teams. And these teams are put together because they have knowledge of the particular areas. And so when you're talking about a team for osteoporosis, you're going to have, of course, initially your physician. You're going to have a nurse. You're going to have your nurse assistant to help, especially help you get the program going. You're going to have an occupational or a physical therapist who's going to help set a program. When you get into definite exercise, when you regain mobility of the joint or flexion of the joint, then you're going to have a kinesiologist come on board to help you establish your exercise programs that will help you get this particular knee lacking in pain and swelling. And if none of this works, then you meet your orthopedic surgeon, and that's when you head for surgery. There is one other treatment which your physiotherapist will talk to you about, and that is bracing. And there are many types of bracing. So you can actually brace your knee, especially if you're trying to avoid surgery. And once your knee is braced, then you can walk, you can take it off when you want, you can do many things. You don't have the flexibility. It does not necessarily cut back on the pain, but it does help cut back a little bit on the swelling. So it'll very, very much depend upon the individual. And I've already talked about this slide, which is really important on some of the effects of physical activity, but we want to be certain that you realize that physical activity will help decrease the pain. It will increase the range of motion. It'll increase your muscular strength around the joint. And it will help you get back to doing active daily living. But it does not prevent the onset, and it does not prevent the progress very much of the disease. It slows it down, but it does not prevent it totally. The other thing that is very important, and why it's so important to have a team working on your knee, and that is because you want to be certain that you've got every factor related to the arthritis taken care of. Well, there are 10 principles established by the Public Health Service and the Arthritis Society of Canada that are very, very important, and you'll be able to take these off the slides whenever you so wish. But I'm just going to briefly, even though we're a little late getting started, I think we're reasonably on time. But these are really, really important. It's important that you increase the strength around the particular joint where you have the arthritis, or the joints you have the arthritis. And there are many exercises to be done to do this. And these, you'll get this information in certain instances from physiotherapists, but primarily from kinesiologists. And what you're trying to do is improve function and health status, in particular, people with knee and hip osteoarthritis. There are few, if any, contraindications of exercise to strengthen, in particular, around hip and knee joints. For those people who have suffered from spinal osteoarthritis, then of course you know that you would not do exercises that are known as crunches. And any good exercise leader is well trained, in particular those from the Canadian Centre for Activity and Aging, and I'm well aware of those through Alcoa, Manitoba, the trainers They know which exercises are contraindicated. And so the onus is upon the individual to go to the instructor and say, okay, I've got spinal osteoarthritis, or I've got arthroplasty of knee, or whatever it might be, and let that instructor know so they know what exercises not to let you do. It's also very important to increase the general fitness of the whole body, because there are so many carryover values from that. One of the obvious ones, of course, is to cut back on overweight or even obesity, because that not only leads to other problems such as type 2 diabetes, heart problems, and so forth, but it will help decrease the pain by taking pressure off various joints, etc., etc. Your exercise program should be individualized. Every person with osteoarthritis has it differently than any other. So make sure that you have a good team to work with, a good kinesiologist or physiotherapist, so that you can have an individual program. Make sure also that you understand the education behind learning about your arthritis. And there are 5 principles of education that you should be aware of that really help you to understand. The first one is try to limit the amount of information you process at any given time. There is just a tremendous amount of information out there on osteoarthritis. You can't read it all. You can't understand it all. You don't need it all. So take it in chunks. Learn a little bit at a time. Secondly, especially those of us who are getting older, and when you're working with older people, make sure they write down the specific questions for the situation. It will help them remember, it will help them learn, and it helps them keep a written account of their exercise program and the problems that might be related to what they're doing. Number 3, gather a few good resources. You can go to the literature, to PubMed, to a library. You can find books and articles written on this. Keep up to date. Just use the most recent literature, unless you refer to some old literature, because the information hasn't changed. But always choose reliable and current resources. So, for example, never, ever go to Wikipedia online. If you want the best information in the world on osteoarthritis, it's in Canada, and you go to the Health Canada website, and you've got the most up-to-date, best literature that there is. And I'm not saying that because I'm Canadian. I'm saying that because that is the truth, that Canada is in the forefront of working with the seniors, working with aging process, and especially working with exercise and aging. So make sure that you go to the Health Canada website. And if you want clarification or information, go to the right contact information. And once again, you can go to Arthritis Canada, the Osteoarthritis Society, or once again, you can go to Health Canada. And just so important, and they have some really very, very good websites for you to go to. Okay, the next principle on the 10 that we're going to talk about is group exercise and home exercise. Some people say, oh, it's better to go out with a group. Others say, no, it's better to do it at home because I feel comfortable. Well, there's no literature to show that one is better than the other. The only problem with home exercise is attrition. People do not stick with the program. They either get too comfortable, their favorite show is coming on TV, the refrigerator is too close, and they after a while, many of them can become couch potatoes. And part of the problem, of course, is related to the fact that there is no follow-up with the hospitals on people with osteoarthritis. So if you have severe osteoarthritis, and you're at home have a problem, it's very difficult to get home help, home assistance. You certainly won't get it from the hospital. probably you'll need to get Victorian Order of Nurses or an organization like the CCAA that can send somebody around and help you out in that particular instance. And these principles are really good for you to remember and even copy later on. So adherence is a real problem, which we've already mentioned too. And then you want to go to strategies. And there are strategies to improve maintenance and so forth. And these are related to the educational principles that I gave you just a few minutes ago. The other 10 principles all fit in very nicely. But how do you are there other ways to get around this? And there are, and I will go over those in a moment. And remember, the effectiveness of your exercise is dependent upon the severity of your particular joint that has a problem. The more severe the problem, the less exercise you can probably do because it was diagnosed too late and you got around to that particular, taking care of that problem too late as well, and the vicious circle has begun, and now you're probably going to end up in surgery, if you wish, or severe, strong of some particular note. Who is responsible for your exercise program? You are. And that is very important for people to remember. You play an integral role in the design, the implementation, and the management of your exercise regimen. You're doing the exercise. You have to let your team know the problems. They can't put an exercise program together for you if you don't give them the information. If you are one of the attrition group, if you don't get back to them as often as you should. So you are responsible. And there is no way for passing the buck. You just go farther down the slippery slope. And the progression continues, and that's when you end up in surgery. Fortunately or unfortunately, I would suggest to you it is not a lot of fun. So for your prescription, here is what to remember. Prevention is the key, and that's why we're working so hard in Canada today to get young people to carry out exercise. You want those joints to be in as good a shape as you possibly can as we get into our senior years. Because once you've got OA, there is no cure. You can't get rid of it. But it doesn't mean that it's part of the aging process. It just means that it's been going on so long that you're going to continue to have problems. And then you go back and you look at your risk factors and you say, okay, I'm the problem here for most of these risk factors. I can affect my level of fat. I can affect my muscle weakness. I can affect joint injury, and I can look after occupational stress with no problem whatsoever. I should tell you that the Arthritis Society of Canada has come up with 7 adjustments to help you manage your arthritis. And I know some of you people on here now are still in the workforce. Some of you are not in the workforce but were. And some of you are seniors and you're going back to work again. I'm a senior. I'm proud of it. I want you to know that I'm still working. And I'm happy to work in. And I work out every single day for minimally 1 hour at 70% of my max, plus my flexibility exercises. And as a result, I don't feel my age. I feel much younger. My O2 uptake is younger. But it's not only now is it that the workforce is starting to understand occupational stresses. So there are many major employers now who are helping out with these particular stresses related to arthritis. And here's the 7 that are published in a book called Arthritis in the Workplace. And you can get a copy of this book at no charge from the Arthritis Society. Really, really important that they have this. And here are the 7. Number 1, perform important duties during the time you feel most energetic, not during the times when you have the pain and the swelling. Secondly, alternate your duties to prevent strain on certain muscle groups and joints, and switch between sitting, standing, and walking. There are many businesses and industries today now who are giving people opportunities to do their work in different positions or to switch off with a cohort. So this week you're really suffering from pain and swelling and you need to be in a sit-down position, for example, and you can change your job with the person next to you who's in a standing position. A lot of industry and business are doing this today, especially when they want to keep good employees. Thirdly, which a lot of people are reluctant to do and forget, apply ice during your lunch break or after work to reduce pain and decrease the swelling. None of the 20 minutes on, 20 minutes off, and then with heat. It's 20 minutes of ice on, 20 minutes off, and on and off, and you can do that as many times as you like until the pain is gone and the swelling is gone. Really quite important. Number 4 may not seem obvious to you, but it certainly is, and that is get adequate sleep and maintain a regular routine of physical activity. Really important. You know how you feel when you didn't get a good night's sleep. Well, you may not realize it, but your knee may feel the same way. So help him out, or whatever other joint it might be. Maintain a healthy weight to reduce pressure on your joints. We've talked about that quite a bit. Number 6, eat healthy foods. Because healthy foods, especially foods containing omega-3 fatty acids, such as salmon and some nuts and sardines, have been shown to reduce inflammation. So if you don't like those particular foods, you can go to a food guide and you'll find other ones that do have high quantities of 3 fatty acids, omega-3 fatty acids, and you can help yourself reduce the swelling. And the other one is always remember, especially if you have spinal osteoarthritis, that you can do shoulder exercises when you're at work, when you're at play, when you're doing things, and such things as shoulder stretches, neck turns, other simple exercises. Do it at your workstation, and then you'll feel much better, and at the same time, it's paying you to work. So that's not all a bad thing at all. You also have to remember that you have in your body what's known as a kinetic chain, and that is so that if you have an ankle problem, it'll soon become a knee problem, it'll soon become a hip problem. So you've got to get to the underlying problem to make sure that it does not increase. And so when you have an ankle problem and you change your gait, well, that's going to affect the biomechanics of your knee and your hip, and it's going to gradually move up, and you're going to have many, many more problems than you did before. So, the last few pages on here, which I'm going to skip through quickly because of time, you can get them afterwards, are just a very brief review of things that you can do for exercise. And what effect that they have on the exercise. Aerobic strengthening, physical strengthening through resistance training, very, very important for osteoarthritis. Manual therapy that you'll get principally from your physical therapist or perhaps a massage therapist if you have one in your area. They can do particular exercises that will help you as well. And always remember, whatever program you're using, try to do about 10 to 15 repetitions. Perform a minimum of 2 days a week, more preferably. Use 8 to 10 different exercises that train the major muscle groups so you can strengthen your joints, and this will contribute to your overall fitness and therefore your other problem. Remember, you're not the only one in pain. Stick to that program, because if you don't stick to that program, there is nothing that anybody can do for you. You are in charge yourself.